Good morning, everyone in Nepal, and good evening, everyone in Canada. I would like to welcome everyone for this third session of the Pediatric Palliative Care Eco Session in Nepal, and we are very proud to have all of you in our program, and we are very proud to have assistant from the World Child Collaboration as well as from the Hyderabad team for running this program. Today, as a special guest, we have got Dr. Stuart, who is the director of the Two World Cancer Collaboration. So, on behalf of all the participants and faculties, I would like to welcome him to this program for today. Before starting this program, we'd like to hear a few words from Dr. Stuart.
Well, I'm just joining to catch up with all the amazing work. I hear about it from Megan and Kummer and other people. It's very wonderful what you're doing. So I'm just basically catching up a little bit. Normally I can't join you on this time, but I've taken the day off today so I can do it especially. So thanks for all you're doing. It's wonderful. We've also got Leslie joining us from Canada as well today, who is with the Two Worlds general team and looking to learn from your work to do some sort of echo for adult palliative care doctors or oncologists and etc. across Nepal. So you guys are leading the way very much. I'll just keep quiet, otherwise learn from you. Thanks very much.
Thank you, Dr. Stuart. He is the driving force behind all this program that we have been running, and we are really glad to have you for the first time in our session. Now let's move on to our today's session. Today's topic will be palliative care issue in adolescent, and Dr. Spandana will be the speaker for this. Today's host will be Saskriti, and Chok will be there as a co-host. I myself, Dr. Sudhir Sapkota, I'm pediatric hemato-oncologist in Kanti Hospital, will be your facilitator for today, and Dr. Sunny will be there for backup. Today's key learning points will be collated by Dr. Hema Joshi, and me, myself, and Dr. Peter will be there in the uh, chat box. So to make this session more interactive, I again request everyone to have your questions there in the chat so that even in limited time, our faculties will be able to answer your questions. And after the speaker will be followed by a case presentation from Dr. Sudeep Chandra Subedi, and Sunny and Dr. Sunny and Sanskriti will be the timekeeper for today's session. Before we begin our session, just a reminder for everyone to keep yourself mute unless you are speaking, and you can unmute yourself when you have any queries after this session. And also, please be active in the chat and put your questions in the chat, because we want it to be more of an interactive session and it to be a two-way learning session, because we are here to learn from your experience also, and we are here to share our experience. So it should be like an adult learning process. So to start today's formal session, I would like to request Dr. Spandana Raela. She is the anesthesiologist and pediatric palliative care expert from the Hyderabad team, and she is also very much oriented and dedicated towards the research activities in both in the pediatric palliative care and other medical fields. Over to you, Dr. Spandana.
Thank you, Dr. Sudhir. As much as I want to be an anesthesiologist, sadly, I'm just a pediatrician who did pediatric palliative care. But thank you, Dr. Sudhir. I would like to wear a lot of hats. And today we are going to talk about palliative care in adolescents, and I'm not going to go into the details of every aspect, and I would like to concentrate more on what are the differences that are seen. Before we go further, I would just like to ask you to take 1 minute and think about your own adolescent experience. All of us have gone through that, and I would like you to think about how did you feel at that time? How long did you think it lasted for you? and what different changes were happening in your head, in your way of thinking, in your body in general, uh, what was happening to your relationships with your parents, with your friends, with your siblings. So, and what was your general idea of what you wanted in life at that point? So, just take few seconds to think about it, and we'll go ahead with this presentation. So for some of you, it has been quite some time, but for some of you, it's fairly recent. And when I think about being an adolescent, this is what I think of. Like the children are those cute little things, those those chicks. Sorry. Whereas you grow up into this hen kind of thing, which is all put together, knows what it wants to do. But then this middle age group, these uncertain, kind of ugly looking, so called not a chick, not a hen kind of thing. So, this is what adolescence reminds me of when there's a lot of uncertainty. So, if you have thought anything different, please share it on the chat. We would like to hear more about it. But these are my thoughts about my own adolescence. And coming to the definition of adolescence, it's the period between the onset of puberty and also the achievement of adult growth and behavior. So there is, WHO says it's between 10 to 24 years. So you can see that it's a wide range of definition. So it starts at around 10 years and it ends at around 24 years. And we don't know if we have to call them a child, young adult. So we are using all these different terms during this time. And age, again, it's only a convenient way to define, but it's only just one of the characteristic. And if you think about age, I think we all know that we define age mostly because of the pubertal changes that happen during that period, but we are not taking into account a lot of social transitions that happen. And why are we talking? Why are we giving a complete session on adolescence in this pediatric palliative care discussion? Because one thing we have to remember is that it's a wide range period and several changes are happening in them and the requirements are changing. So when you see a 10-year-old and when you see a 16-year-old, the approach is going to be completely different to that young adult, adolescent. And we, as pediatric palliative care physicians, nurses, the healthcare professionals, our services have to be ever evolving when we are seeing this particular group of population. So, what do we aim for in palliative care for adolescents? So these would be very, very general to what we think for in pediatric palliative care. We want to improve their the quality of life and decrease their suffering. And also we want to help them to adjust to the changes that are happening in their body and also in their thinking and the view of their world. And also, as time goes by, children become more and more autonomous. They want to be more independent. So, a 5-year-old is more than happy sometimes to listen to their parents, but as age grows and they get more independent, they want to have more independence. So, that is something I think palliative care team has to support and maintaining their social context, the relationships. Sometimes they're going to school, sometimes they're not going to school, sometimes they have a lot of friends, sometimes they don't. So everything comes into account. And I think we have spoken about hope in the previous sessions. So they keep changing their hope just like parents do. Initially, they would be more than happy to get rid of the disease. And then sometimes they do have to come to terms that the disease is going to be with them. And then they start thinking how well to live with that disease. And sometimes they know that the disease is not going to go away and they're not going to live for a lot of time. So, how do we help them adjust to the changes in their hope too? And also helping them to live well as for as long as possible. So these are some things we keep in mind when we are seeing adolescents. And so I think few of you must have thought about what all happened in your own life as an adolescent and few extra things that happen in adolescents and young adults are One thing they question a lot is their self-esteem. They might not feel very confident, or sometimes they look very confident, but inside they are not very sure. They do have body image issues. They worry about how they look, and their emotions are flowing a lot. Uh, and again, they're worrying about their career and education. They do think about finances again, because they are thinking about the healthcare cost for their family. They understand all that at that age. The family dynamics are changing because of their illness sometimes, and because of other things. A lot of times the future plans are at hold. So if you have seen adolescents in your practice, think back, and most of them say that they wanted to be something big, so they wanted to do something big, and this is what happened, and the future plans are at hold. Regarding fertility, you might wonder that why would adolescents, a 15-year-old, a 16-year-old, wonder about fertility? It so happened that I saw a testicular cancer child at 16 years of age. And prior to radiation, they did talk to them about sperm banking. And this 16-year-old was expressing to me, he was crying, saying that, can I ever have children of my own, a 16-year-old. So all this goes on in their mind. And peer relations, coming to hospital regularly, being away from their regular life. A lot of effect is on with their friends, and their school friends and friends at home. So we have done the four categories of pediatric palliative care, but in when we come to adolescents, we are not thinking about those categories as such. We are thinking about what are the new conditions that get diagnosed at 12, 13, 14, 15, 16 years of age, and we are thinking about new conditions such as cancer. Many of you work at cancer hospitals, so you do understand this. And sometimes they have a trauma, and they end up having a quadriplegia, hemiplegia, and they have to live with it for the rest of their life. It's a new condition. Sometimes there is a new onset renal failure. And yesterday I've seen a bone marrow failure syndrome in a 12-year-old. So that could be a new condition. So new conditions are something that are diagnosed in their adolescence. And long term with increasing disability. So these are diagnosed in their childhood, when they are infants, when they're toddlers, but they continue to live with it and they grow up to be adolescents. So these are Duchenne muscular dystrophy, cystic fibrosis, and then there are some conditions which get diagnosed early, some during adolescence, but over a period of time they're reasonably stable, and they have to live their life around and along with this condition. For example, cerebral palsy, HIV on treatment. So before I go further, take some time and think about it. Think about cancer, trauma, the new conditions. So you're a normal adolescent having future plans about having a normal adulthood, and you have a lot of things going on, and you're diagnosed with this particular condition, or a particular event happens to you and you end up having a palliative care condition. So the adjustment, the thinking, the support they need would be a completely different thing compared to someone who is diagnosed at 1 year, 2 year, and now they are 14 years. So the way they adjust to it, the outlook of it is completely different. And every time our team sees an adolescent, we have to keep this in mind. And for example, a child with diagnosed with cancer at say 7 years of age, and now the child is 12 years of age and has a relapse. So now the child has information which the child has acquired from 7 years old, which other children at this age wouldn't know. So the 12-year-old might make different decisions compared to a 12-year-old with a newly diagnosed cancer. So the way we approach to them is completely different. Their worries might be completely different because of the experiences they have had. So the context becomes very, very real and very, very important when we see adolescents with different conditions. So I just want to share a story with you. Ramu is a 16-year-old adolescent who is newly diagnosed with osteosarcoma following a trauma. He's school going, he's an athlete, he loves playing, he is highly driven to succeed in life, because he has a widowed mother and has a younger sister. And because of cultural reasons, he thinks he has to take good care of his mother and young sister, and he's very, very driven towards it. And because he's so driven, he's so hardworking, he's loved by everybody, his teachers, elders in the village, and he has a ton of friends. And he also does a part-time job in the evening in a shop, and he gets some money back home to support his mother. So now imagine this is the backstory of Ramu, and now he's diagnosed with osteosarcoma, and he is in pain. And can you think about what are the worries Ramu has? What would be the multitude of things that are going in his mind? You can put it on chat, and we'll go forward and we can discuss more on it. So few things are, he's worrying about the tumor. He must be worrying about the pain that's coming and the meaning of it, and the physical dependence. Earlier Ramu was doing all his activities on his own. Now he needs help from his mother and his younger sister, whom he's supposed to take care of. Now they're helping him go into the toilet and use the toilet. And his role in the family, till yesterday he was going to be the boss of the family, he's going to take care of everybody. Now suddenly the roles have reversed, they are taking care of him. And the financial burden, his mother is already burdened and he has taken responsibility to try and help, and now he's no longer able to do that, and there are additional costs for his own healthcare. The body image issue. Earlier, he had a lot of friends, he could move around, and now he's stuck in the bed, and his friends are coming to see him sometimes. And loss of connection with peers. The friends are still able to go on with their life, but not him. And he loses connection with the day-to-day activities, and the social stigma that comes with cancer, especially coming from rural background. And even in the cities, we have seen that people think that cancer spreads from each other. So there might be parents who prevent their children from seeing this adolescent, and also the spiritual distress. Why is this happening to me? I am a good boy. I have been a good boy, and I have lived my life. I have tried to be the best possible person. And why is this happening to me? So these are several of the worries that might be going on in his mind. So there are critical elements in palliative care. This is from a paper from 2011. And along with what goes on in their mind, what is happening in it, we also have to think about the psychosocial needs of the family. Again, newly diagnosed versus they have been living with it for a few years, the way they look at it. And what happens to friends who themselves are adolescents and not certain what is happening, and also the caregivers who are with the adolescent 24/7 taking care of them, and introducing palliative care again to the patient family, and also to the healthcare other healthcare professionals and the other disciplines, and having requisite resources. As you have seen, adolescent care can take a fair bit of resources, and advocating for adolescents. So one more thing we have to think about is that maintaining meaningful and enduring relationships would be a huge challenge for the adolescents, especially when they're not well. And they themselves have identity issues about the changing worldview and about love, about so if you go back and think about your own adolescence, you would probably have liked a girl, a boy, and so the way you look at it would have changed. And about work, we have spoken a bit about it. And also we do have to remember that adolescents are prone to risky behaviors due to several reasons. And they like to take look at it in a different way compared to what an adult would look at it or a child would look at it. So we do have to understand that, and we do have to deal with that. And sometimes when we see these children, they tend to live for a longer period of time. And we do have to remember that we do have to help them with their training and education. Sometimes we have to sensitize their parents about it. And other challenges that we face are lack of time for us, the healthcare professionals. A lot of time we have to concentrate on the quality of communication rather than the quantity of it. We should have sensitive discussion around prognosis and even involving the family about what to expect in the future. And talking to adolescents is a huge challenge even when they're healthy, and to talk to them when they're not well, to answer their questions can be a huge challenge. And for this, even as palliative care professionals, we would need help. And if you're someone who is practicing on the side, you would need further guidance from psychologists and people who have experience doing that. And there has been a study. I think this was close to around 2004. This study has been published. So this is about parents who have spoken to their adolescents about how the disease is progressing, and which is not a good thing that is happening in their life. And 100% of the parents who spoke to the adolescents felt that they have done the right thing by speaking, but 27% of them who did not speak felt that they should have spoken. So speaking to adolescents, keeping them in the loop is a huge thing, very important thing. And there are some normal milestones that get threatened by these life limiting conditions. So, one thing is that pubertal development may be delayed and they may not be normal to their peers, and their cognitive abilities and their reasoning is changing. So, that can be a huge challenge to the parents. And I have seen few children who look like children, or whom are looked by their parents as children because they're on bed, they need all these help because they're dependent like small children, but then their brain is on par with their peers. So they question their parents, and the parent feels hurt because the parent is doing everything, but the child is not understanding it. So there is a lot of emerging sense of identity, and they're worried about their body image, and they want to be very independent from their parents. And there is a lot of change in the relationships that they have. Coming to things that might be a bit similar, symptom management is quite similar to what they do in adults and also in pediatrics, if you think about it. The symptom management is fairly very similar. We are using the same medicines, we are doing a bit of play, we are involving other modes of treatment. And one thing I think is very important, not just in pediatrics, but also adolescents, is explaining what the procedure is and taking consent. So adolescents, they don't like being walked upon. So you cannot come and say, "Come, I'll examine your abdomen." Just turn around without saying what you're going to do, what you're looking for. I think it needs a little more time. And we do have to remember that adolescents are a huge age range, and at some point they become able to give consent legally. So we have to be aware of what exactly are the legal age for giving consent in our countries, and act upon it. And then the psychosocial issues can be multiple things. There can be more suffering sometimes than children because they look at their suffering with a different lens. And sometimes they can act out, sometimes they can reject treatments outright without thinking further just because they don't want to do it anymore. And also there is a high risk of not being compliant with treatment. So children, you give a tablet, they take a tablet because the mother is giving. But with adolescent, it doesn't work out that way. They have to take the tablet, and sometimes they don't want to do it and they don't do it. So we have to understand why there is incompliance for treatment too, and what we can do for them. We can help them by engaging them in meaningful activities and also allowing them to express themselves. So there can be some things that you can do. Again, different settings, different things works. Uh, Poetry works, music, dance, art or creative activities. Sometimes just making them tell a story brings out so much out of them. Therapeutic play is also for adolescents, but again, there are different things that they enjoy. Starting peer support groups in your hospitals might go a long way. And how do we help them stay connected with friends in school? Can we facilitate that? So these are few things we can think about, and these are some things we can help them do. Spirituality. So this is one thing I think, again, we think, do adolescents have spiritual crisis and existential loss? Isn't it too early to have all that? So a lot of times, again, adolescents are thinking, why is this happening to me? Why should it happen to me? There are other friends of mine who are totally fine, who have everything going well, but why me? So there can be anger towards their parents, especially if it's something that they have acquired during the time of birth, and if they think it's the mistake of their parents. And so all there are a lot of emotions, and there are a lot of spiritual crisis events that can happen to them during this age group, and we have to be sensitive about their questions. And communication, I think this is one of the most challenging group, because uh, because of the psychology that comes with the adolescent age group. And also there can be different meanings to different words. We can say a thing in a different meaning and they perceive it in a different meaning. And a lot of the adolescents are always with the phone, their head is in the social media. And one huge challenge I think is, now adolescents are always on the Google, and they know what is happening to them, and parents don't want them to know the collusion. And how do we break it? We know that the adolescents know, but the parents don't want them to know. So bridging that gap, and the age differences, a 10-year-old is very, very different from a 19-year-old. And how do we cross that barrier? And asking questions like, what gives your life meaning? What is the purpose you wish for your life? And these can be huge challenges when it comes to communication. And always remember, adolescents have a lot of hopes, they have dreams, they have plans. Most of them have been cut short by a diagnosis. So they might find meaning in having different hobbies. They dream about their careers. They think about their legacy. What am I born in this world for? What am I leaving this world with? And what memories they're creating for themselves. And also, uh, they how do they find connection if they're stuck in a room 24/7? How do they find connection with others, with nature? How do they connect with God, the spirituality part of it? And sometimes they lose connection with their own self because of the diagnosis. So how do we help with all that? And then there are legal and ethical issues that come with the whole thing. Uh, how about consent and assent, and also end of life care? It can be a bit more challenging because of the questions they ask. And I would like you to think about this story that I'm going to share with you, a child we have seen, an adolescent we have seen. Her name is Seema, and she's 14 years old. She's diagnosed with HIV at 10 years of age. And the history being, she received a blood transfusion at 7 years of age, and none of the family members have HIV. So initially, she had been incompliant because of various reasons, and she had severe infections. And pediatric palliative care team was introduced at that point when they thought that the child is going to die with those infections. But then she recovered, and she stayed with the team, and she's on regular ART now, but we are in follow up because we want her to take that regular ART. She goes to school, but her previous best friends and her close cousins, close family members don't talk to her anymore, maintain the distance. And now she has different set of friends, but then she holds the diagnosis of HIV close to her heart. She doesn't tell her friends that, see, I have this, I have to take this medication for this reason. It's not that she has to tell the friends, but this is something she feels she has to hide it. So again, what must be going on in her? And the major issues she shares with the team are her body image issues, about friends and relations, and her sexuality, because 14 years she hit her puberty, she achieved her menarche, and her body has changed. And all her friends talk to boys, so she wants to talk to boys, but then she wonders, what does that mean? Should I have to tell the boy that I have HIV? And then she also wonders about marriage in the future, about having children. So will my children have HIV, and can I marry someone should I marry someone who has HIV only so that I don't give it to somebody else? So these are all her questions that go on in her mind. And I don't think these are some things they will ask us in the first consult or first time we have this conversation. And these questions are expressed after I think it's over months and years. She thinks it is safe to ask these questions. So I will end this because I think I'm crossing so much. I know this is a huge topic and I have just touched upon them, but we would be more than happy to hear your questions. And with that, there's one more thing, and that is transition to adult services. So is it letting go if we transition them to adult services, or do we keep these children with us forever? So I think I'll not go into details of this, but this is also something we have to think about. Do we keep them in the child group, or do we transition them into the adult group, or how does it work with our individual programs? So with that, I end my topic. Sorry.
Thank you. Thank you, Dr. Spandana. Thank you for that wonderful speech. Definitely, the adolescents, they are in the transition phase, and many of the time they can think, but they can't do anything, and they can't decide about many things. They are uncertain about many things, and talking about the adolescents, the stress of puberty, along with the stress of disease, sometimes even breaks them down. So, and many of the times, even the parents are unaware about the expectations or the behavior of their adolescent kid. And if we are able to counsel them or have a good rapport with them, then many of the times the children, adolescent will listen to their own doctors rather than their parents also, because they have got that feeling of being individual and being independent also. So we won't be taking questions now, but just one question to Dr. Spandana. You have mentioned about the therapeutic play in the in your presentation. Can you just elaborate few words about how it is done and what it is actually?
Thank you. So next week we are going to talk more about play and therapeutic play. Kamara is going to walk us through that. But Kamara has put up a comment, and I'm going to read that up. Do you want to answer that, Kamara? Because you have put it up anyway.
Yeah, Kamara, you can answer that, please.
Sorry. So
Thank you. Yeah, it's just therapeutic play is using play as a medium for children to be able to express emotions, solve problems, gain mastery. Play is a natural medium for children. And then what the hope is that you have a therapist or other clinicians or even volunteers that are trained to support children of all ages with different mediums. So for an adolescent, and actually Spandana gave some beautiful examples like poetry. One of the things that I like to do with adolescents is to say, can you share with me some of your favorite music? And so very often that music has themes that are really, really important. They often have themes of doing battle or having loss or having fears. And just playing that music and talking about that music can be really helpful for the adolescent and helps us gain more knowledge about them. Thank you.
Yeah, thank you, Kamara, and thank you, Dr. Spandan again. Now, anyone who has further queries can put their questions in the chat and we'll move forward. I'd like to ask Dr. Sudeep to present with the case, and he's a medical officer who initially worked in the pediatric oncology unit and he has been shifted to the surgery unit recently. And the other thing about him is that he has actually initiated a study in the pediatric palliative care in Kanti Children's Hospital. He has done a baseline survey, and I think he has collected all the data, and we are expected to get the full study within 1 or 2 months. Over to you, Dr. Sudeep. Dr. Sudeep, are you there?
Am Am I audible?
Yes. Yes, you are audible. You can go.
Thank you. Can I go through my presentation? Can you help me with the presentation? Can I?
Yeah, I'll
Okay.
end the screen.
Okay, thank you. Hello, good morning, and namaste to everyone. Today is a part of ECHO II, week 4. I am glad and honored to present a case under the topic palliative care issues in adolescence. And without delay, I would like to proceed to my case presentation. And for today's presentation, following are the key questions. Breaking bad news to adolescents and their family, psychological counseling for adolescents, multidisciplinary approach for management. Next slide, please. Regarding the patient details, today I am talking about a 13-year female adolescent child. She's Mongolian and with diagnosis of acute myeloid leukemia along with insomnia. Regarding the treatment, she's currently under induction chemotherapy for acute myeloid leukemia, and she has already taken first course of chemotherapy. At presentation, she presented clinically with symptoms of acute leukemia, for which we done peripheral blood smear, which shows around 35% blood cells, and after that we gone for bone marrow aspiration and flow cytometry, which shows acute myeloid leukemia, and we started the treatment. Regarding her current admission, she's she presented and she presented with hemoglobin of 6.4, for which we transfused packed red blood cells, and she also got platelets of 10,000, and total count was 400 with absolute neutrophil count 16. These are the symptoms of current admission. She got fever, for which we gave her paracetamols and antibiotics according to the sensitivity. And she got mucositis, for which we consult her to give, counsel her to take gargle, povidone gargle, and mouse gel containing metronidazoles and chlorhexidine. She felt weak and was pallor, and for which transfused blood, and she complained of difficulty to sleep, so we consult psychiatric, and she also had nasal bleeding, for which we did nasal packing. Tranexamic acid was given, and plasma rich platelets was transfused. Next slide, please. Next slide, please. Regarding her psychological and family concerns, she belongs to a joint family where she stays with her grandparents, her uncle, aunt, and other siblings. Her mother is a foreign employee. She used to stay abroad, but with her diagnosis, she came back, and currently she is with her mother. And his father is construction manager. In their regarding their financial concern, currently they have to stay with their child a rented room nearby the hospital. So they have lost the job, and they are facing the financial problem. And the positive thing is that they are hopeful regarding the management and care. And However, they refused to openly discuss the child's disease condition and its prognosis, thinking that might decrease her willpower. Regarding the spiritual concern, uh, she follows Christianity, and the family has strong religious devotion. Uh, in the child remembering Jesus, feel that it will decrease her stress, fear, and negative thoughts, and it increases her self-esteem and willpower. Regarding the communication, I will prefer to say she is extrovert, and she expresses her feelings through writing song, talking with her mother and her close friends, and she wants to share her feelings and thoughts. Um, and she correlate her symptoms to overthinking and vice versa. And she's worried about her hair loss. However, she's optimistic and that she will be disease free in near future, and she's unaware of her own condition. Regarding the collaboration and partnership, uh, she's under dietary consultation, and we have consulted the psychologist for her symptoms. And according to her mother, she had previously applied for life insurance, but due to different causes, they could not pay the installments. And however, they are planning to join the government health insurance policy, and they have got the government $1,000 fund scheme to life-threatening illness. uh, and I'm at the end of the session, and about the summary of today's presentation. She's 13-year-old Mongolian optimistic adolescent girl with recently diagnosed acute myeloid leukemia, undergoing induction chemotherapy at our center, developed nasal bleeding, mucositis, and fever, which is being treated. And her issue is parents prefer not to discuss the openly discuss the disease status and its prognosis with child, assuming she will lose her willpower or hope, and the child is anxious and worried about her condition. In the and she is also worried about the parents, and in meantime she has developed insomnia. For all this, we have started curative along with palliative therapy. Regarding the key questions of today's presentation, child is unaware about her disease condition, and parents prefer not to discuss with child, assuming she will lose her willpower or hope. How to deal such a complex situation? It might be under the breaking bad news or communication to adolescents. And the second is, could some of the physical symptoms be attributed to her lack of knowledge regarding her disease? And is there a role of psychologists? And regarding the management, uh, what else could have been done? Thank you. Thank you for listening.
Thank you, Dr. Sudeep, for this wonderful case presentation and going into its questions. Maybe I would like to ask Kamra to answer the first question. Break the bad news to a patient in such cases, and especially when the parents they don't want to inform their children about the diagnosis. So we should be counseling both the parents and the children also. So your thoughts on that, Kamra?
Thank you so much. That was a great presentation. I think the first point is to really listen to the parents. They are trying to do their very best. And I would say spending time with the parents, asking them, tell us what you think she understands what's happening to her body. Tell us what you think she might be worried about. And tell me more about what your worry is about what's happening to her. And when we explore this way, then parents will often realize that their children, their young adolescents, probably know something more is going on than they're letting on. And in that way, you open up the conversation so you can provide them with some good information. We know from research that when parents don't share information with their child or their adolescent, the child can have more fear and feel more alone. And perhaps this is partly part of the problem with her sleep. The other thing is we know that the adolescent, even if she can't talk to her parents, she will find somebody to talk to that she trusts. And when she trusts a nurse or a psychologist or a doctor that sees her every day, she might ask a question that is hard to answer. She might say, "Why am I getting this medicine? Why is my hair falling out?" And before we answer the question, we should say, "Oh, tell me why you think it's happening," or "What do you think is going on with your body?" And remember that if someone has asked you that question, a big question that's hard to answer, it's because they trust you. So pause and share information the best you can. One of the ways that, and we talked about this before, is give them a bit of a warning shot. That's a big question. I'm wondering if I can share with you what I think is happening. In that way, we're preparing them to hear about the information we want to deliver. So those would be a little bit of my advice around the dynamic of parents and adolescents not sharing information.
Thank you, Kamra. And again, back to Dr. Spandana. So in our setup, usually when the rights of the children are very ignored, especially the rights of the adolescents are ignored, so it is very hard and difficult to convince the parents that the information should be provided to the children. So how can you share your experience, how you have been tackling such situation to convince the parents that the proper information should be given to the child?
Firstly, I would like to say that it was a great case presentation. It's a great case to talk about. One thing you will definitely, at least especially because we come from very, very similar cultures, we will definitely face a challenge would be trying to tell the child in the initial few consults. So the parents are not sure what you're going to say. And so they're going to say that, no, don't talk, don't talk. So, and that is okay. It is not necessary that we tell everything just because the child is very anxious. I know we want to do the best, but if the parent doesn't agree and if we tell, we are going to ruin our relationship with the parents. They're never going to trust us again, and they're not going to come to us. So what we do is we know we need time, and we take that time. We build a relationship with the parents and the child, the adolescent as such. And the parents see over a period of time how we talk, and they know that we never say anything hurtful, and they know that we have the best interest in for their child. And then they also see how we interact and how the child responds to us. And it is completely different from how the child responds to any other healthcare professional. So the parents over a period of time come to us with doubts, and then they start saying that the child is acting out. Can you talk to them? Can you find out why she's not sleeping? She was crying for the last 30 minutes. Can you please come and talk? So sometimes they do that, and sometimes even we say maybe it is time we find out what the child knows. So sometimes if we say that I want to go and talk, they will say no. But instead I say that, okay, let me just find out what they know. I'm not going to give any information. I'm just going to find out what they know. And I'll come back and tell you what they have told me. And then we will decide what is the best thing to do next. So it is a lot of collaboration with the parent. It is a lot of negotiation. It is like going to that open market and bargaining for that. Give me for 100 rupees, give me for 110 rupees kind of thing. Like we just want to build it step by step, and that is what we do.
Yeah, thank you, Dr. Spandana. Definitely. And we need that bargain, and that will be after the bargain, even the parents will be convinced to that. And but the other thing is that it will be time consuming, and we should not be hurried upon to disclose the information, and we should be patient to that. So now a quick question to Rampukar Sa. Rampukar, are you there with us?
Yes, sir.
Yeah. Just so this child has not been disclosed about her condition. So, and in the meantime, she has developed insomnia. So, how do you manage such cases in which maybe the psychological symptoms are attributable to her anxiety and fear? Just can you give your view on just a
Yeah,
short?
sure. I guess we have been looking this case under our team, and good thing is that we have started. We have She is very communicative. This case, and we have able to develop some relationships. So what Camera told us, like developing a relationship is very important. So we just try to establish a good rapport. We try to just listen to her, what's her concerns, and try to find out. And interestingly, in this case, she is more interested on art. So she was very interested in art. So we use the art as a medium. And also for engagement, we plan for, like, she loves to read stories. And so in management part for her somatic complaint, basically for anxiety, we have started deep breathing just to make her calm down so that she can receive the information. So initially, when I started communication, she was really anxious, and I just listened to her and just to calm her down. It's a simple skill like deep breathing, and then to develop further relationship, we have this art. Since she likes art, as Camera mentioned, it's important to know. And also, as Dr. Spandana mentioned, that what are the hobbies of the child. Like being adolescents, they would love to talk about what are their, like, interest rather than listening our interest. So that's where it's important that we figure out what is the child interest in. So in this case, with the further management, we can go with the simple breathing techniques, which has helped her to decrease. I have taken 2 sessions with her for now. And for her sleep with insomnia, I've just consulted with our psychiatrist team. So they started with clonas in SOS basis for medicational part, so that she can sleep, so that she won't be irritated and aggressive towards parents and towards us. That will help to build further relationship. So the now plan is to work with the parents so that we make them understand what is the importance of disclosing the information. And child herself knows so many information, and she's worried that if anything, that separation anxiety feeling is still prominent in this case. So it's very important that this aspect is dealt. So I have requested parents to please inform wherever they are going, please pass the information when they come and go, so that still feels safe. So these are small technique, but yes, in days to come, we have to be patient, and then we have to disclose the information by developing relationship.
Thank you. Thank you, Rampukar sir. Definitely, there is no doubt that the children should be informed the truth, and uh, many of the time, we, to tackle with the psychological issue, we don't have to generalize the patient. We have to actually individualize the patient and see what are the needs of the adolescent, and then work accordingly. So the last question was, what else could have been done? I think Rampukar has already answered that question. He has shared his plans also. Now, I would like to bring out another question in discussion. The last slide of Dr. Spandana, she had talked about the transition. And regarding the transition from pediatric to the adolescent age group, how do we do that transition? And is there in the typical age group? I think we had few discussion about this regarding the same in chat also. Dr. Megan, uh, would you like to share your experience how the transition is done at your center from the pediatric palliative care to the adult-based palliative care?
Yeah, so we transition them at 18 to 19. If they look like they will live at least a few more years. If we think their time is short, like under 1 year, then we probably will not transition them. But we may ask them, talk to them about what they would like to do. Say, this is the age where usually you would start seeing an adult physician, what would you like to do? Because I also want to respect them as autonomous adults, essentially, that they've become an adult in our society. At 19, people are really considered an adult. And so we don't want to keep them in a child hospital, child hospice, child palliative care setting, because maybe it's diminishing how they feel. So I actually asked them if they would like to go to be treated at an adult, or if they would like to stay at the pediatric, just based on what their preference is. And it depends on the child and the family. We aren't really able to keep them. We don't have the same flexibility that some programs have, because the Ministry of Health won't fund us to take them. They say they have to go to the adults. So if they're going to be alive for more than another year or so, they do have to eventually get transitioned. I think that what you said, Sudhir, is very nice, to do a combined visit or do some overlapping follow-up, so that there's a good transition. And I usually call and speak to the physician that I select the physician that I'm sending the patient to, and I speak to them and make sure they're comfortable, because sometimes the diseases are new for adult palliative care physicians. So you have to find someone who's a good fit, who is willing to do something that's a bit different and has that comfort level. And you offer that you would continue to provide support and advice and really encourage them to work as a team with you and transition them. But in the US, they basically never transition patients. It's a very broken system in some ways. And so they have like 40-year-olds who've had congenital heart disease who still go to a children's hospital. And if you're 40, it's not the right thing. You don't want to be at a children's hospital. You feel that this is not the right place for you. So I think we have to make sure that we do, if possible, offer them services that are age appropriate. The best would be to have what we call AYA services, adolescent and young adult, where you really recognize exactly what Spandana said, that this group has unique needs and characteristics, right? It's a very defined period where people have different needs than children, but they also have different needs than older people who need palliative care, right? If you're 24 and you have cancer, it is a fundamentally different experience than if you are 50 or 60. It is, you're young, you're just coming into your adult life. It's a totally different experience, and they don't mix so well with the much older patients either, right? So they do need a special attention to those details.
Yeah, thank you, Dr. Megan. Definitely, we can't say that, okay, the child is more than 14 years, more than 18 years, so you should visit the adult one. There should be a smooth transition, because smooth transition and to relieve the suffering has been the only motto of the palliative care. So that can't be abrupt. Many of the time, what happens is that even when we send the child to other center for consultation, they will come back to you, okay, this doctor has asked me for this thing, shall I do this thing or not? So the trust, the rapport that you have built over the 5 years, 6 years, you can just let it go in a single day, because that was the birthday of the child and he has grown up. Few last thought from Dr. Krishna Sagar. What's the system at your center regarding the transition?
Thank you, Sudhir. We do see the patients up to 19 years from the OPD. So most of the adolescent will come to us directly. Even our recent online management system, they have to enter the date of birth now. So this will directly come to the pediatric by default. And we physically see, and we do our best, and then we send to other instruments, radiotherapy, surgery, like that. So I think I am seeing from long time the up to 19 years, but there is lots of issues, very much confusing, because we are not much adolescent carer, just like expertise, though we have study on that. But some of the patients who are 24, 25, still they love to see us. They want to consult us, and then we almost, even after 19, we ship them the adult, but we welcome them and they used to follow up. Even they come to the adult side, they used to visit us and they have lots of questions, and they used to happy with our consultation, even informal talk, like that. So up to 10 to 12 to 24 in the developed country maybe, but we have to consider them to give the support as much as we can do, though it is not that adapted in Nepal. So I think adolescent, and maybe they want to go after 19 is okay, we can let them to go the adult side, that we ship them to the adult side, but they used to come, even their marriage, even their issues for the childbearing, and even after that they have the children, they used to come us with us to show the children and then their issues. So I think this is the adolescent is a very big and specialized area. So we need to be expertise not only in the care to the palliative and support also. So even we are the pediatric side, our help and our suggestion, I think it works wonderful to them, then they love it. So that is my experience in my center. Maybe in Kanti also, they were considering the adolescent health. In Dharan, they have the adolescent health clinics, even like that. So maybe we have to switch on maybe from the pediatric, adolescent, and then young adult slowly, so that we can meet the maximum expectation of the pediatric and this age group. I think that's my situation and this my experience.
Yeah, thank you, Dr. Krishna Sagar. As he's mentioned, it many of time it happens that we are treating one child and we have got such a good rapport that even when the older sibling gets some other symptoms, they will bring the children to us saying that you have been taking care of our younger child, so this child also you should be taking care of, because we have built such a good rapport. In that case also, we should respect the trust that they have shown to us in that case. So any last thought from any faculties or any last question from the participants before we wrap up the today's session?
Thanks very much, Stuart. Here, thanks very much. I think just a very quick thought in strategic sense. We know that Nepal and countries like Nepal have a large number of children with palliative needs, and that's going to be reflected by the number of adolescents as the children, as time goes forward. That sort of bulge is going to go through the adolescent group. So I think in terms of strategic planning for palliative care with the government in general, this needs to be highlighted. So thanks very much. It was very interesting.
Thank you, Dr. Swart, for comment. Any other views or any questions from the participants? So this brings us to the end of today's session. Thank you everyone for your wonderful participation. And in the upcoming sessions, we would like to have further more active interaction in the chat. And in the meantime, you can put forward your questions in the WhatsApp group also. Our faculties will be more than happy to answer you. And you can also share your experience, and that will be the learning point for our faculties and for other participants also. Always feel free to be in touch. We shall meet again next week at the same time. So goodbye for now. Stay safe. Bye-bye.
Hi, everybody. Nice to see you all.
Bye-bye.
Thank you. Bye.